understands you.
Inshallah.
Starting the live stream.
Dear participants, our today's topic is Stop Missing the Nerve, a practical guide to mandibular anesthesia, presented by Dr. Batool Sajjad from Pakistan, who is an oral surgeon. Dr. Batool Sajjad also is a MCBS CHPE scholar and an assistant professor of oral surgery. She is also a published author, both national and international. The floor is all yours now, Dr. Batool.
Dr. Batul, the floor is yours. You may start the presentation.
Assalamu alaikum. How are you guys? Good afternoon, good evening. I know there'll be people from different part of the world connecting in, so whatever works for you. I hope you're keeping well. I hope you have a great day. We're going to talk about a topic, about a procedure that is probably the most frequently performed procedure in dentistry, yet it is the more also the most understated skill, underestimated skill. It's like the underdog. Before I move on, I want to say, if there's any point that you cannot understand, or if I'm not audible, you can always let me know somehow in the chat, or to the host, so I can repeat myself. Anyways, so I was saying local anesthesia is probably the most frequently performed procedure in dentistry, yet is also the most underestimated skill. A good injection would make you invisible, and that's what you want to the patient. You don't want hovering over the patient. A failed one will make you unforgettable in not in a very good way, trust me. One of my supervisors, actually, I really look up to him. He would always tell me, Batul, make sure that you give profound anesthesia. And that is your first step towards success. And I would wonder, what does he even mean by that? We simply meant was once your anesthesia work, the patient would be a patient would be more confident and would show more trust in you. And when those things happen, when there's more trust, more confidence, your job becomes a lot easier. So I want to know, like sometimes I wonder to myself, what is more stressful? Is it the fact that, extracting the tooth, or the procedure that, that follows, or the fact that, that you might have a failed anesthesia? I think, I mean, hands down, a failed anesthesia, is more stressful. Anyways, they've already introduced me, but I'm just going to talk about myself a little more, because who doesn't like talking about themselves, right? So I'm Dr. Batool Sajjad. I have been practicing dentistry for the past 15 years, and I have been associated with oral surgery for the past almost 10 years, most of those time. And what I do believe in is a good dentistry starts with a good anesthesia. So when they told me that I need to talk about something oral surgery that will be relevant, relevant to final year or house job or the new dentist, I couldn't think of anything more relevant than local anesthesia, because numb patients, because of local anesthesia, are happy patients. Okay, before we start injecting imaginary patient in our heads, let's quickly look at what all we're going to achieve in this session today. We're going to understand the mandibular nerve anatomy. We're going to go through a base of it, because again, I'm going to quote my supervisor on this. My supervisor said, oral surgeon cannot be a good oral surgeon if he's not good with his anatomy. Somebody who is good with their anatomy will be a good surgeon. Identify clinical landmarks, describe various mandibular techniques, and we're also going to perform stepwise administration of those. Okay, let's quickly go through the indications for local anesthesia. Actually, all the procedures that we perform in dentistry do require some kind of numbing technique. Either it could be exodontia simple, or could be endodontic treatment, or could be a periodontal procedure or minor oral surgery procedure such as biopsy or suturing. Okay, moving on. There's always a difference between a mandibular and a maxillary anesthesia, and we by experience and by knowing that, we know that mandibular anesthesia is more challenging. Sometimes we wonder why. Most of the times we wonder why. It's because the bone is different for mandibular when compared to maxilla. Maxillary bone is more porous, that makes infiltrate a possibility, while mandibular bone is more dense. So block anesthesia is more of a choice, or a more of an option for mandible when compared to maxilla. Again, with mandible, because of its anatomy, because of the anatomy of the nerve, and because it's deeply embedded and there could be variation in it, the accessory information, it makes it, it's a lot more complicated when compared to maxilla. And this, again, when there's complication, there's higher rate of failure. But I'm not trying to scare you here, I'm just trying to state the fact, so when we go in, we go informed. So yeah, moving on. um Mandibular anesthesia is basically applied anatomy. If you understand the nerve pathway, the injection becomes more logical than memorized. And always logic wins. And logical is something that you will also remember for longer. So now we're talking about mandibular nerve, which is a third division of the trigeminal nerve. So the divisions are ophthalmic, maxillary, and mandible. We're going to focus on mandible because we're going to eventually talk about mandibular local anesthesia. It's a mixed nerve, and it exits the skull via foramen ovale. The major sensory branches of mandibular nerve are inferior, lingual, buccal, auricular, temporal, mental, and incisive. In the mandible, we are mainly targeting the inferior alveolar nerve, but we cannot forget its neighbors like the lingual nerve and the long buccal nerve, and sometimes the mylohyoid nerve. That's like a mischievous one. I'm going to tell you why. I'm going to talk about how it can lead to failures of even a perfectly placed inferior alveolar nerve block. Sorry. Let's talk about the course or the let's talk about the course of inferior alveolar nerve. It enters through mandibular foramen, and it travels in the mandibular canal, as you can see, and it divides into mental and incisive nerve. Okay. Now let's see what each of them supplies. So the lingual nerve would supply the 2/3 of the tongue, while and the lingual gingiva, while the mental nerve would supply the chin and the lower lip and the chin of that side. The long buccal, the buccal mucosa, and inferior alveolar nerve supplies all of the mandibular teeth. Okay, there are various type of mandibular anesthesia. There's inferior alveolar nerve block. There's a Gauge. There's the closed mouth or echinocele block. There's mental, incisive, and long book. We're going to talk about all of them a bit in detail. The important word, we're going to like really dive in and see the landmarks and whatnot, and then we're going to see what we can do about that, how to administer and all that. Excuse me. Let's talk about inferior alveolar nerve block. Mandibular anesthesia is all about landmarks. If you can identify the coronoid notch, if you can identify the pterygomandibular raphe and occlusal plane, you're already halfway to a successful block. So I've tried marking all the I've tried marking all the landmarks for your understanding. You can like we often, like students often focus on the needle depth, but experienced clinician would know where the anatomy or where the needle start or where the anatomy is. Okay, so inferior alveolar nerve block is one of the most commonly used mandibular anesthesia technique in dentistry. Despite being in routine, it has one of the most highest failure rates, mainly because of the landmark errors. So we're going to talk about that in detail. Almost every dentist remember their first failed inferior alveolar nerve block. You always, it's very close to your heart. It's something that you take home with you. You live with that. It's like extracting a bad tooth, or extracting a tooth that was very difficult, that stays with you, and a very bad local anesthesia also stays with you, because sometimes you have done what you could have and still it's a failure. We're going to tell you why. I'm going to tell you why. Okay, now what really happens is the local anesthesia is deposited near the mandibular foramen. It blocks the inferior alveolar nerve before it enters the mandibular canal. So let's go back. I'll show you where exactly I'm talking about. When we talked about course, so local anesthesia is deposited near the mandibular foramen. Before it enters the canal, so it actually numbs the nerve. So often anesthetize the lingual nerve as well. The goal is not to numb the tooth directly; it's to block the nerve before it actually reaches the tooth. So we spoke about the coronoid notch. So what you have to place a thumb on your coronoid notch. So if you think about coronoid notch, it's actually a concavity that you can feel it. It's like a bulge, actually a notch that you can put your thumb on. Okay, that's one thing. The pterygomandibular raphe is actually a vertical mucosal fold. That's one, and the occlusal plane. If you think about these three sides, the coronoid is the distal, the pterygoid mandibular being the medial, and the occlusal plane being the base of it. It makes a triangle, and if you can just find the midpoint of that triangle is exactly where you want to place your needle in. So if you see that cross that I've marked is exactly the injection site. Now I'm going to put on a video and we're going to talk through the video, so then it makes more sense to you. One second, I'm going to play this up. I hope we're all doing okay till now and we're alive and happy. Okay. Okay. This is they're just denoting the coronoid node, the trigeminal nerve into buccal, inferior and lingual nerve. So the position of the patient would be in this. I'm going to talk about the position here because I'm going to. There are other anesthesia or the types of another anesthesia. Actually, the only difference is the fact that the way they are, the position of the patient or the way you want to place your needle in. So here the patient is going to have their mouth fully open. And why? Because opening the mouth stretches the tissue and moves the mandibular foramen into a more accessible position, because that's where you want to deposit your local anesthesia. So you have to ask the patient to open the mouth fully, and that will make your life a lot easier. Once you ask the, I'm going to play this. Once you ask the patient to open his mouth fully, you'll be able to identify the landmarks. There you see it's a coronoid process or coronoid notch. You place your thumb and you stretch it towards yourself. Then you want to go contralaterally. Contralateral means from the opposite side. For example, if you're working on the right side, from the contraline, you mean on the left side, you want to go between 4 and 5, the first and the second premolar. That's where you want to, address it from. You want to take your needle, or you want to take your injection from contralaterally from that side, and 6 to 10 millimeter above the occlusal plane, and go all the way to 3/4 distant from the coronoid notch, or 6 to 10 millimeter from the occlusal plane. If you can see the point of insertion, excuse me, you have to go about 20 to 25 millimeter in depth. This is a very important point. The reason you want to go in that depth is because if it when you go there in that depth, you will be able to, there'll be a bone contact. There'll be a bone contact, and that's so important. If there's a bone contact, that you're on the right spot. When there's bone contact, you remove you pull out the needle a bit, and then you slowly and gradually, taking at least a minute to deposit the solution. I'll tell you why you want to do it slowly and why you want to hit the bone. If you hit the bone real quickly, not to 25 millimeter, you hit it very, very quickly, then you know that you have hit the external oblique ridge. You're not in the right landscape. That's a wrong, you're in the wrong anatomical position. So it's going to be a failure. Okay, one thing. Why do you want to deposit slowly and gradually? Why do you want to take a minute? It's because you have to imagine that this place is a closed cavity. And it's very tight, it's very turgid, there's no space. And when you try to put or deposit any solution, it's going to give a stretching pain for the patient. There's going to be a lot of pressure pain. So what you can do to make their life easier, it's slowly and gradually deposit. So then there's a less pressure on the patient, and the patient is more confident, less anxious. Bone contact is important. Tells you the needle is in the correct place. Okay, let's play this. Sorry, it's taking a while. There you go. You aspirate a little to make sure that you're not in a vessel. But if you follow the anatomy, you are not going to be in a vessel. There's no vessel around there at that time. Inject slowly, take 60 seconds per cartridge. And as you withdraw the needle, make sure that you deposit some more. And that way, you're going to also numb the lingual nerve. So yeah, you anesthetize the lingual nerve on your way out. It takes about 3 to 5 minutes to anesthesia to work. And how do you know, okay, it's a success? The lower lip will be numb, the tip of the tongue will be numb, the patient will there's a soft tissue anesthesia. When we ask the patient the heaviness, oh, do you feel that heaviness? It's not because of inferior alveolar nerve block, it's usually because of the long buccal. For inferior alveolar nerve, you need to see the lip, the tongue, and the soft tissue. Okay. I also want to talk about another, and what all will it anesthetize? It will anesthetize mandibular teeth on that side, lower lip, chin, buccal, gingiva, anterior to the molars, and anterior 2/3 of the tongue, because of the lingual nerve. Okay, Nir, I want to take a minute and talk about something, and before we move on, let me finish this video. Let's see if we've missed something on this. Sometimes you've followed all the anatomy, you have followed all the points that you had to do, and your anesthesia is a failure. As in, your lip is numb, but the lip is numb, but the tooth is still active. It still hurt when you try to luxate or you try to do a restorative work. One of the most common reason for failure is accessory sensory fibers from the mylohyoid nerve. The mylohyoid nerve usually it's also a branch of the mandibular nerve, a mandibular division of the trigeminal nerve. It usually gives fibers to the mylohyoid and anterior body of the digastric. But sometimes it gives you sensory fibers to the teeth. And that's when you don't account for them, because this is not a normal or usual circumstance. This is like a unique case or a very anatomical variation. So in that case, your block, even though you've placed it properly, it will still not be functional. You will still have to supplement with few other injections, like intraligamentary or intraosseous. We're going to talk about that in a bit. But I want you to know that sometimes even a perfect block can be a failure because of the anatomical variation. So main causes could be injection too low, too anterior, you hit the bone too quickly. So all of them can lead to a failure. Most of the failures are because of anatomical positions and error. And remember that mandible is always less forgiving than when maxilla. You miss the landmark by a few millimeters, the nerve probably ignores you completely. It ghosts you. You have to repeat it. So in the end, in the end of the inferior alveolar nerve block, I would want to say that it remains the foundation of mandibular anesthesia, but its success depends heavily on accurate landmarks, identification, and correct needle positioning. I hope this was clear. We're going to move on to the next technique, which is the Gauge technique. Okay, it's also called as high mandibular block. When the conventional inferior alveolar nerve block keeps failing, the Gauge technique it comes in as a superhero. It's often the solution because it blocks the nerve higher up before it branches. Think of it as switching from blocking a small road to blocking the whole of the highway, because it actually anesthetizes the whole of the highway and the whole of the trunk rather than just a part of the branches. It was introduced by George Albert Edwards Gauge. It's kept on the guy who actually discovered. It's quite self-absorbed here. It's considered as a true mandibular nerve block. Anesthetic is deposited at the near of the mandibular condyle. If you remember, the inferior alveolar nerve block, the anesthesia was deposited at the mandibular foramina before it enters the canal, the nerve. Here, it is a deposit near the mandibular condyle, like the lateral part of it, and it blocks almost the entire mandibular division of the trigeminal nerve. So therefore, it will anesthetize the inferior alveolar nerve, lingual nerve, long buccal, mylohyoid, and a part of auriculotemporal sometimes. Instead of chasing individual branches, what it does is Gauge blocks the entire trunk before it enters. So then you have a hemimandibular block. We're also going to talk about the landmarks here before I show you another video, so we can talk through the video also. Here you have extraoral landmarks and you have an intraoral landmarks. The extraoral landmark you have to remember from the corner of the mouth to the to the tragus of the ear. You draw an imaginary line. This is where your needle is going to go parallel to. So imagine you draw a line from the corner of the mouth all the way to the tragus of the ear. The needle is going to go parallel to it. This is the extraoral landmark. Intraoral landmark is the mesiopalatal cusp of the maxillary second molar and the pterygomandibular raphe and the condylar neck. This is where the target is. Your target is higher than there was from the inferior alveolar nerve block. It's close to the condylar neck. Okay, let's watch the video and I'm going to talk through it so then you understand. And we're also going to talk about a bit of the differences. Okay. It's a unilateral jaw, teeth, cheek, and anterior of the teeth. Here the target is higher. It's at the condylar neck. So you ask the patient to open the mouth as wide as they can, and they have to keep it open. Why do you want them to open as wide as they can? Because wide opening makes the condylar forward, makes the target area very, very accessible. You can see here also. It will just the mouth, when the mouth is completely open, the mandibular condylar would be at the articular emissions and it would be more approachable. You can approach it very, very easily. So you want to ask the patient, you can always use a bite block also, but initially when you're placing the injection, you want to ask them to open as wide as they can. Okay, so this is one of the drawback also. We're going to talk about why. Okay, now let's do this. Yeah, because here is where the target nerves are located, because it's coming down or descending from the condylar. So you want to pinch them where you can actually get the whole trunk together. You ask the patient to open his mouth completely, and you draw it imaginarily from the corner of the mouth to the tragus, and you have to keep, that's the extraoral landmarks, and intraoral landmarks you want to keep the mesiopalatal cusp of the secondary maxillary molar. You insert the needle, tip of the needle inserted to just distal to the maxillary second molar at the level of mesiopalatal cusp. If you aim too low, then you're basically doing a inferior alveolar nerve block. The idea is to aim high. aim for the sky, aim for the stars. Idea is to aim high and nip the problem in its butt where before it branches out. The whole trunk has to be anesthetized. So yeah, but if you're not right in the height or if you're not right in the landmark, then it's essentially just an inferior nerve block and not the Gauge technique. Along the imaginary line towards this, you again the depth should be about 25 millimeter. You do not want to go beyond that. And there, here again, as we spoke about an inferior alveolar nerve block, there was a bony contact. Here also, the bone contact appears at the condylar neck. Bone contact is essential. It's vital. It confirms that you are in the correct level. If you do not hit the bone, then you're not in the correct level. It's going to just be another failure. What you can do is you after you do that, you aspirate, usually low positive aspiratory, but you still aspirate and inject slowly over 60 to 90 seconds. You need to gradually deposit the solution, and even after that the patient has to keep his mouth open for another 1 to 2 minutes, because this helps anesthetic diffuse around the nerve trunk. So overall this is a little dramatic for the patient also, that to keep the mouth open not only towards through the procedure, but even post procedure they'll have to keep their mouth open for another 1 to 2 minutes. Here you can actually ask the patient put on a bite block and let the patient be in some kind of less stressful condition. Because why do you want to keep the mouth open for another 1 to 2 minutes? Because that will help to dissolve, or they will diffuse the around the nerve trunk. Okay. The onset is slightly lower. It's about takes 5 to 7 minutes, but higher. But again, but the success rate is very, very higher. It anesthetizes the area would be the mandibular teeth on that side, buccal and the lingual soft tissues, the floor of the mouth, and anterior two-thirds of the tongue. All of them would be numb with this. Often you don't even have to do a separate buccal nerve, a long buccal nerve block. Something often you what you can do is you can do the Gauge technique and wait for another 5 and 7 minutes and then check. You might not even need to do a long buccal nerve block. So that's an advantage. It has very high success rate. It blocks the accessory innervation, like for example the myeloid of sensory fibers that we spoke about. It has a lower positive aspiration rate and useful in whenever there's a failure for inferior alveolar nerve block for whatever reason. You couldn't find the bone, your anatomy was not that great, or whatever not. You can always go for Gauge. It solves many of the anatomical variation that cause conventional block to fail. For example, whenever there's sensory fibers from the myeloid nerve, when there's accessory fibers. So when you do a Gauge, it actually sorts that issue. So whenever there's a failure for inferior alveolar nerve block, you can always turn to Gauge to be your confidant that it's going to actually sort the issue and it's going to solve the problem. I want to be very honest about it. Now that I've told you all the benefit that Gauge have, and how beneficial it is, and what kind of edge it has over inferior alveolar nerve, but it is not very commonly used, especially by the young dentist, simply because you require the patient also not very comfortable, because you have to do a very wide mouth opening and for longer time. It has a very long onset, as in it takes a longer, about 5 to 7 minutes. So that's not very, the patients are very anxious. Excuse me. Imagine if you have to sit on that unit. Have you guys ever sat down on that unit? It's very, very painful to actually sit down and stare at that light. So for patient, this increases the chair side time for the patient. So that's one thing. And it's more technically demanding, to be honest, initially at least. So yeah, so that it's not very commonly used, only in the cases of failure. One second, I'm just gonna. One second. Sorry. Okay. Now we're going to talk about one of our last technique in detail. After that, we're just going to touch other techniques. But this one is another technique. It's called close. Excuse me. Excuse me. Excuse me. One second. It's called closed mouth technique, or as Vesirani. It's a tongue twister for me. It's a Vesirani Echinosi technique. It's again it's named on the the scientist or the dental surgeon that actually discovered it. Now imagine you're sitting in your OPD. It's a normal OPD day. You're sitting in your surgery department. The 38-year-old male patient complains of painful lower ache since last 5 days. He's already been on antibiotics. There's no comorbids, and you want to do an extraction of this teeth. On probing more, on asking on a history and on history, you realize that patient is a known has a habit of known pan chali or betel nut chewer. So and when you do an examination, he cannot open his mouth. His mouth is completely shut. It is literally no mouth opening. There's trismus. What will you do now? You have to pull out the tooth. TK, but there's no mouth opening, and mouth opening is because of the pain usually, right? And if you do the anesthesia, it will open up. So now how will you do the anesthesia, right? So now you can do a technique called closed mouth technique, as the name suggests, or very Vezirani echinosi technique. I'm going to not do that word again. I'm going to use it as closed mouth technique. It was developed by Verinazi and Echinosi. It's the anesthesia is deposited in pterygomandibular space without a bony contact. If you remember, inferior alveolar nerve block, the anesthesia was deposited at the mandibular foramen. The gout gates we deposit at the medial or the lateral surface of the condylar neck. And here we do, and in both of those cases, there were bony contact that we knew there was a success. But in this, we do not have a bony contact. We have we have to deposit in a pterygomandibular space, and there's no bony contact. Blocks the mandibular nerve branches at a higher level. Basically, instead of asking the patient to open wider, this technique adapts to the patient's limitation. Whatever the limitation of a limited mouth opening, a TMJ issue, you can adopt to that and makes the patient more comfortable and less anxious. So you can use it when the patient complains of trismus, limited mouth opening, TMJ pain, there's a trauma, or there's been a failed inferior alveolar nerve block when opening it, or when opening is difficult. That, that the patient does not have a limited mouth opening, but there's a difficulty in opening this, and you cannot look for all the landmarks. So you know that if you attempt inferior alveolar nerve block, or if you've attempted inferior nerve block, you feel there was a failure because of the because of the identification, not proper identification of the landmark. So you can always use this. When the patient says that I can't open my mouth, you say no problem, oh, we can always use this technique. Acha, unlike inferior nerve block and Gauguin's, landmarks are softer and positioned. There you had the inferior alveolar nerve block. There are landmarks for pterygomandibular raphe, the coronoid notch, and the occlusal plane. For Gauguin's, you had your own. You had the mesopalatal cusp, and the neck, condylar neck. Extraorally had the corner of the mouth and the trachea. The landmarks are very the softer and positional. There's a basically you have the landmark is the mucogingival junction of the maxillary molars, or the maxillary tuberosity region, and the occlusal plane. So because the needle needs to travel parallel to the maxillary occlusal plane in a closed mouth. Does that make sense? Okay, I hope it does. We're going to watch another video and I'm going to talk through it. Okay, the nerve here, almost everything that is done by a Gauguin, but it's a closed mouth technique. So inferior alveolar nerve, lingual, mylohyoid, and often the long buccal nerve also. You often achieve anesthesia similar to Gauguin, but without mouth opening. Okay. So that's there, and I'm gonna skip it a bit so we can move to the areas. The area anesthetized is all of the mandibular teeth, the long buccal, the lingual, soft tissue, and all of them will be anesthetized. Now we're going to talk about the position here. So I'm going to skip it a bit. Okay. So yep. One second. I'm just gonna skip this here. Okay, so step one is that the patient position has to be closed mouth. It already makes the patient less more anxious when you ask them to close their mouth and not to wide open. It makes patient more comfortable and more and less anxious. So even when the patient does not have a limited mouth opening, it does not have any functional concern, you can still an anxious patient. You can all still ask the patient, you know what, close your mouth. It's okay. I'll manage. You know, you can do that also. Okay, after that you it takes about 3 to 5 minutes, the onset about 3 to 5 minutes when done correctly. And then what you can do is you ask the patient to open close the mouth or open it slightly if possible, and then you laterally retract the cheek and you place the needle at the mucogingival junction of the maxillary second or third molar. You see at the mucogingival junction at the second or maxillary molar. Insertion is higher than the inferior alveolar nerve block, but it's lower than but it's lower than but it's lower but it's lower than Gauge for sure. So it's somewhere in the midway between the inferior alveolar and the Gauge. You have to advance the needle parallelly to the maxillary occlusal plane. You have to go almost about 25 millimeter in, and there again, there's going to be no bony contact. Unlike other mandibular block, absence of bony contact here is actually normal. It's not an error. Okay, you aspirate carefully, inject slowly. Again, you do one cartridge over 60 seconds. So it has a lot of plus points to it. Like for example, it's ideal for trismus patient, for anxious patient. It's less traumatic. It's comfortable for patient, useful for alternative when there's a failed inferior alveolar nerve block. It converts a difficult patient into a manageable procedure. But what I need to be honest about, because there is no bony contact and all the landmarks are softer and positional. So what happens is it required a very good anatomical visualization that might not come very early on for you guys. It might need a lot of experience of doing Gauge, doing of a conventional inferior alveolar nerve block for you to master this particular technique, because it does not have a bony contact. So you do not know, like even now when I do it after 15 years, it always makes me a lot happy. It always makes me happy and satisfied that I've hit the bone. I know that I'm on the right path. Closed mouth technique do not give you that kind of satisfaction. It really humbles you. So your orientation replaces bone contact as your study guide. Okay. This is basically a dentistry plan B when the plan A is not working, when the patient is not, opening his mouth or whatnot. All right. Let's move on towards the end of your, almost towards the end. Don't get too excited. We still have few slides to go, but we're going to go over it quickly. This is one table that I found, and I found it really interesting because if you learn this, or if you have a concept of this, you actually going to be okay. You will be able to choose wisely what to do when, because again, making a decision is very, very important. Once you've graduated, it's one of the most taxing and something that having the confidence, and the confidence only comes from knowledge. The eyes only know what the brain only knows what eye sees, kind of jazz. If you only know, only then will you be able to function it. So when you compare the inferior alveolar nerve block to Gauge to the closed mouth technique, they are there again. The indication is routine failed and when there's a trismus. And over here we spoke about the onset. The longest is the closed mouth. The longest is almost Gauge and closed mouth techniques. The inferior alveolar nerve block is a quicker technique, and that really, really helps because again it reduces the chairside time of the patient. Success rate is highest for the Gauge, but again it's more sensitive, technique sensitive, and the fact that the patient has to keep his mouth open not only during the procedure but post the procedure for 1 to 2 minutes for it to diffuse around the anesthesia to diffuse. It's a bit of a put off. Let's talk about the long buccal nerve block. But I just want to you to learn, like summarize the 3 blocks. Like inferior alveolar nerve block requires your mouth to be open. Gauge requires it to be really, really open, like really widely open. And the closed mouth or the echinosis works when the mouth you cannot open it at all. Let's talk about another technique, which is a long buccal nerve block. You do it to the distal to the last standing molar. Even if you're pulling out the first molar and there's a second molar or a third molar, you have to put distal to the last standing molar into the soft tissue, to the mucosa, distal to the last standing molar, regardless of whichever tooth you're pulling out or whichever tooth you're working on. You still have to go distal to the last standing molar, and it anesthetizes the whole of the buccal mucosa. Then you have a mental nerve block. A mental nerve block is basically ideally for a premolar 4 and 5. What you're assuming is that you're actually that the mental you are injecting or depositing the anesthesia into mental foramen. You're assuming that ideally also, the mental foramen is placed between 4 and 5, right? So you're assuming that, if I go right in midway between 4 and 5, I'm going to deposit my anesthesia into the mental foramen. But that's an ideal situation. There could be a variation, there could be an anatomical variation. Okay, so, it could be a little medial, it could be a little lateral, so sometimes it is not that accurate. There's another way of doing it, is that you draw a imaginary line from the going midway from the supraorbital notch to the infraorbital notch to the upper 4-5 to the lower 4-5. That should be, all of these are aligned with the mental foramen. Or there's another way of doing it. This is one way of doing it, that we do it. There's another way that's the exact or proper way, is that you raise the flap, you identify or locate the mental foramen and actually inject the anesthesia there. So yes, but usually in the OPTs we don't go so dramatic, we don't do such drastic steps. We just assume and hope that the mental foramen is between 4 and 5, and that's when we place it. And we usually use it only when we want to do premolar extractions, for example in ortho cases, where they would want you to extract 4 or 5, or when there's a BDR, when there's a child that needs extraction of only the premolars. Okay, now we're towards the end of our session. I just want to talk about the primary techniques that we spoke about, the mandibular anesthesia escalation ladder. The primary techniques are inferior alveolar nerve blocks, the Gaugates, or the closed mouth techniques. Again, you have to use those first. If something happens and then you cannot, for whatever reason that we're going to talk about, there are other supplemental techniques that we're going to talk about right now. The first is intraligamentary technique. The intraligamentary injection, when do you want to use it? When the single tooth needs to be anesthetized. You don't need the whole arch to do it. You don't need the whole quadrant. And so you just need one. When your inferior nerve block is partially successful, maybe there's some nerve fibers that could not be anesthetized for whatever reasons, and you need a boost, so you can use intraligamentary. There's endodontic procedures, they're good. Pediatric, or a conservative dentistry, for example, you do not want to do something drastic, just want to do a little bit of filling or deep filling, you can do this. The solution forced into the periodontal ligament and reaches the cancellous bone. So basically, you have to place your needle parallel to the PDL space, and you have to inject your solution there. You'll feel a lot of pressure, because ideally the PDL space should be really tight and there should not be a lot of space. So when you're injecting, you feel a lot of pressure. If you can see the picture there, it makes you'll know what location I'm talking about. The advantages are that it localizes the anesthesia. There's minimal soft tissue numbness, but again, the drawback is it's for shorter duration, and post-operative soreness is also a possibility. PDL injection converts a failed block into a targeted success. You know what I mean? Like, not like targeted, it's a halfway success, but success is success. The second is intraosseous injection. As the name suggests, it's actually into the bone. You have to drill the bit of cortical bone, and then you have to inject the anesthesia into the cancellous bone. So when you can use it, when you have a irreversible pulpitis or a hot tooth, you have a failed block, or you have endodontic emergency. It perforates. You have to perforate the cortical bone, deposit the anesthesia directly into the cancellous bone. It has very rapid onset, because you are depositing right into the cancellous bone, and it's a very profound pulpal anesthesia. Temporary increases the heart rate, so you have to be careful about that, especially with vasoconstrictive using. So what we do is, on a clinical pathway, is like when you do intraosseous, we use a plain cartridge. When I say plain cartridge, I mean cartridge that anesthesia that does not have a vasoconstrictor, that is an epinephrine, so plain cartridge. So we use that. So instead of choosing the nerve, intraosseous anesthesia goes directly into the bone around it. So it might, a patient might complain of, a palpitation, increased heart rate. So that could all be avoided with a good history, that, there's no, like a pre-existing heart issue. And the fact that you can always use a plain cartridge rather than one with the vasoconstrictor. Okay, the last one is intra-pulpal injection. It's a last resort. You should remember the injection works 100%. The success rate is 100% of the time, but the patient never forgets. It's so painful. It takes seconds and it works, but those seconds are so painful. The patient will never forget. They will always remember this, honestly. But it works 100%. But this should be last resort because it's very, very painful for the patient. So when can you actually use it? When this pulp is exposed, when all the techniques have been exhausted, all the techniques you have applied and you have failed at it, only then you would want to use these. All right. And lastly, when like endodontic access has already been gained, so you can like you've already done the endodontic chamber opening, you can actually put the pulp. Why not? Okay. And the pressure is because of the anesthesia, not because of the drug action, trust me. Okay, always you'll always you'll always see a resistance, because what pulpal pain is a pain because it's a pressure pain. What do I mean by pressure pain? That pain is because there's a lot of pressure that's been built up in a closed cavity. So even if you remember, whenever there's a pus or there's swelling, if you prick it or if you open the chamber and you release the pressure, the pain, even though the tooth is still caved, still infected, the patient will feel will be in a lot less pain because you've released the pressure. So imagine if it's already a pressure cavity, if the pain is because of the pressure, and injecting more solution in it, putting in more pain will just it'll be end game for the patient. So you'll always remember this, but you also need to remember pain for seconds gives anesthesia for minutes. So that's pretty much it. But I wanted to do you to do a little activity. You can do it. I don't know if you can put on your mics or tell me what it is, but I wanted you to do this activity because the idea of this session is for you. You might not, of course, I mean, of course, not might not. You will not be able to just go home right now and start injecting and know what to do and what not. A lot more practice, both theory wise and clinical, is required. But at least if by the end of the session, if you can pick one, for example, if it's a routine dentistry, what technique will you pick? So if for routine dentistry, it will be inferior alveolar block. For trismus, it would be closed mouth. For a failed block, you can use Gaugates. For irreversible pulpitis, you can use your intraosseous. For exposed painful pulp, you can use intrapulpal. For buccal mucosa, you can use long buccal nerve. For anterior mandible, you can use incisive. For single sensitive tooth, you can use intraligamentary. So even if by the end of the session, if you can choose what to give in what situation, we're a winner. We don't want to pressurize you into anything too much. I just want you to know a few things that I'm going to sum up. One of them is that know when to choose what. If you're still up, we're going to do a few take home messages and that will be end of the session. Mandible anesthesia is one of the most fundamental skills that you can have in dentistry. When done correctly, it makes your job every so much easier. Every dental procedure is easier for both the dentist and the patient. Trust me. So, what are the points that I want you to take home? I want you to know that anatomy is the foundation. And foundation anatomy is the foundation. Local anesthesia is really anatomy applied in real time. Whatever you study, you've been studying all this time, and and you're like, where am I going to use all that jazz? It just know that in local anesthesia you're just applying all the anatomy that you've learned all over since your first year. So if you know your anatomy, you're not going to miss on this. Okay? So success of the mandible anesthesia depends on understanding the nerve anatomy and anatomical landmarks. Second thing I want to tell you that technique matters more than the drug. Trust me. Most failures are due to incorrect needle positioning, and not because of the anesthesia was ineffective or insufficient. You have to changing the cartridge rarely fixes the problem. Trust me. Changing the technique usually does. So make sure to remember that anatomy and it's technique sensitive, right? Even when we spoke about the success rate of all the anesthesia, we spoke about like Gaugates have a higher rate of success, but because of its technique sensitive, you don't use it too often. Always remember one technique is not enough. You should be familiar with multiple techniques such as inferior, Gaugates, supplemental techniques, closed mouth, intraligamentary. A good clinician does not repeat the same failed injection. They choose a smarter alternate. For example, if you've done an inferior alveolar nerve block and it didn't work, you repeating inferior alveolar nerve block is not a smart choice. You use an alternative. Okay, you know what, that didn't work out for whatever reason, the anatomy or the variation, whatever. What can I do next? What is my other option? Always have other option, always no other alternative. The fourth point that I want to emphasize on is patient comfort and safety are essential. Always aspirate kind, just inject slowly and communicate with the patient. Patient rarely remember the restoration you would do for them, but they would always remember the injection. Yeah, and they will always say, oh God, the injection was so painful, so they will not remember what you've done for them, but always remember the first prick that you placed for them. In the last I would want to say the mastering mandible anesthesia is not about giving more injection. It's just about giving the right injection. So, but just I hope you had a great time, and I hope you are not sleeping like these teeth, and I hope it was informative for you guys. So I'm just gonna stop sharing my screen, and thank you, you guys. You've been lovely audience. I don't know if you were still up. So
Thank you, Dr. Batool. It's just very informative session, and we really enjoyed it. So there's a question saying, when a standard inferior alveolar nerve block fails despite a classic clinical presentation, how do you systematically roll out accessory innervation from the mylohyoid or lingual nerves versus a high pivot mandibular nerve before switching to an alternative injection?
hi. So as I said earlier, you might not be able to justify it. You might not be able to see that what was the variation. One second, I'm just gonna variation was. But what you can do is, as a smart clinician, you can always move on to an alternative option. You have so many options. You could go for Gaugates now, but if you feel the patient is not very comfortable keeping his mouth open for that long, you can always go for the closed mouth technique. You know what I mean? You do not have to on that point next to the patient need to figure out, okay, where I went wrong. You just need to make sure that you treat the patient at that point. You just move on and then go back and have a feedback. Oh, reflect. You know what I did, maybe I didn't maybe maybe I was not right, I didn't go all the way, maybe my needle was not all the way in, maybe that was the case, maybe my anatomy, my landmarks, I didn't do my landmarks properly. So all that you can reflect that, but at that time you need to be in a solution mindset. You want to make sure that what this didn't work out, no problem, khalas, I'll move on. I'll make I'll make most of it. So answering your question, even when there's something you've done everything all right, you cannot clinically you cannot tell that the mylohyoid fibers, the accessory fibers were there that made you a failed block. You'll have to just move on and give another technique. You can either do a supplemental technique or you can repeat a block. I hope that answers.
Yeah, it answered well. Thank you, doctor. And there's another question is saying, in cases of severe trismus or acute infection where a traditional inferior alveolar nerve block is difficult to landmark, how do you weigh the success rate of the Go-Gates technique versus the Ixnuki-Varzani closed mouth approach for achieving reliable bulbal anesthesia?
Okay, so when there's no limited mouth opening, so you cannot do Gaugates anyways, because the main one of the main indication or main issue with Gaugates is that you need the patient to open his mouth wide open, not only during the procedure, but even post procedure for the first 2 minutes, so that anesthesia can diffuse in the trunk, in the trunk around it. So there's no comparison. You can't compare it. In closed mouth, of course, the closed mouth has a very high success rate when done properly. The only problem with a closed mouth is because when you injecting it, you're not actually touching the bone. There's no bony contact, so we can never be sure. What did I do it right? Did I not do it right? So here your anatomy comes in the play. You have to be such a good anatomist. You should be like, what I did okay. There has to be no bony contact, and I'm okay. My success rate is going to be fine. So you just have to have your anatomy, and the success rate would be very, very high for pulpal and for closed mouth technique. The pulpal rate is high because again you can't do many more other techniques initially. Once you have done your Gaugates and the patient is now able to open the mouth a little bit, because a lot of times when there's a lot of pain, patient will not be able. There's no OSF. There's no functional issue with it for them to open the mouth. It's because of the pain that they couldn't open the mouth. So you've given them the Gaugate. You waited for some time, like 3 to 5 minutes. Now the patient can open their mouth. Once they can open their mouth, you can go for a supplementary technique. You could go for you could go for intraligamentary, or you could go for intraosseous or intrapulpal. But
Okay,
again, there's no comparison between Gauget's and the closed mouth technique
close
in a
mouth.
trismus patient.
Okay. There's another question is saying, does the patient's age affect the injection height? I noticed that in some young or older patients, even with the correct position, I cannot hit the bone. Any advice, doctor? And thank you.
You're very kind. Okay, for younger anatomy again, I'm so sorry. I keep repeating myself about anatomy, but I can't stress enough about it. You need to understand how much my supervisor has done for me. He's been talking about anatomy since the day we entered our residency program. So in kids, in pediatric patient below 12-year-old, um, there's the lingula is placed lower. So when the lingula is placed lower, again your inferior alveolar block, nerve block needs to be placed a little lower when compared to in an adult. And also there's a new formula that I was studying, but I've not read completely. I should have done now. It talked about the age of the patient. How do you know when you can give inferior nerve block to a PEDS patient? It talks about I think it's a new research about 2023, and I'll maybe I'll send you the link also. But what I read was it spoke about that the number of the tooth plus the number of the age of the patient. If it's more than 12, then you have to give inferior alveolar nerve block. Below that, you can give an infiltrate. I hope that makes sense. If not, I'm gonna tag the research so it makes sense. But when you talk about the anatomy for kids are different, or pediatric patients are different compared to an adult. The lingual is placed down, so you have to make sure that you inject at a lower height when compared to in general. For example, if in adults we're doing a 6 to 10 millimeters height from the occlusal plane when contralateral, we have to make sure it's below 6 for the PEDS patient.
Okay. There's another question saying, when practicing in clinics, I sometimes do early bone touch. How do I face a patient later on if such touch keeps happening?
Sorry, what touch? I'm sorry.
I guess she means she can't or she barely touched the bone.
Oh yeah. Okay. Again, there are two school of thoughts on that. I didn't speak about the other school of thought because this is something that I don't agree with. But because for learning purposes, I'm going to share. So there's one school of thought that agrees or believes in the fact that you have to hit the bone. Okay, you have to go 3/4 in and you have to hit the bone. All right, and if you make sure that your needle is about 20 to 25 millimeter all the way in. If you hit the bone too quickly, that your needle is not all the way in, that you know that you're not in the right space, it is actually the external oblique ridge. Okay, the other schools of thought says that if you have mapped your anatomy, the coronoid notch, the pterygomantle raphe, and the occlusal plane, and you inject in the center of this triangle, and even if you go 3/4 way in, like 20 to 25 millimeter in, and you do not hit the bone, you still have a successful anesthesia because the space is right. So even when you hit the bone, you're hitting the bone, but you're withdrawing a bit, and then when you're aspirating with the bone, we know that we're in the right anatomical space. So that's a concept of the bone. So when you do not hit the bone, but and if your needle is 3/4 in, and if you are in the right anatomical space because of the boundaries that you have designed in your head, your anesthesia will work. And for the sake of argument, it doesn't. It doesn't. That's okay. All of us have a wrong day or bad day. So make sure that you ask someone else to repeat either inferior alveolar nerve block or another technique, and it's okay. Even the best of clinicians have a bad day at anesthesia. It's anatomy. You can't. It's a God creation. You can't. Everybody's different. So you are just hoping this is where it is and it should be it is, but it could be up and down. So don't stress about it. Just the phase that you guys are going through is so beautiful. You're just learning. You can make mistakes. Of course, don't make lethal mistakes, but make mistake, learn, and then bounce back. It's fine. It's a process.
Yeah,
Enjoy your
I
dentist.
agree. I agree. The last question is, hi doctor, thank you for your explanation. Do you have any tips for inferior alveolar nerve block in patients with thick mucosa? I experienced difficulties in locating the injection landmarks. Thank you in advance.
Yes. Okay, with thick mucosa, you have to make sure. Now if you're going 20-25 millimeter, again, when we spoke about this, we're going to take this as a uniqueness in every patient. Every patient is different, every patient is unique. Sometimes a mobile tooth can give you that so much pain that even a sturdy tooth will not. So you have to take this as it comes and goes. So if it's a thick mucosa, then you account for those also. For example, if your needle is supposed to go 3/4 in or 25 to 20 millimeter in, the gingiva in the mucosa, then you make sure that you account for the few more extra millimeters that is going to go all the way in. You just have to be a little more, force a little more. That's it, and then hope it goes all the way in, and you'll be great. I know. And if you've encountered that in the clinic, I'm sure you're doing great, better than I was at your age, or whatever age you are. I'm very old, so you must be a lot younger than I am, anyways.
Thank you for advice. So thank you, dear Dr. Batul, for your great and informative session. And on behalf of the IDS SCORE webinars team, we want to extend our sincere thanks for your fantastic presentation on the anesthesia and your practical guide provided our global dental community with invaluable tips to improve our clinical tips and skills. We truly appreciate the expertise and energy you brought us to today's session. Thank you, Dr. Batul. And we look, of course,
No
forward to
worries.
possibility of collaborating with you again.
No worries. You have a great day, and you guys were great hosts. Thank you for accommodating me. You have a great, whatever is left of your day. Okay, take care, you guys.
Thank you. Thank you, dear
Okay, bye.
participants. Bye bye. Dear participants, thank you for attendance and kindly note that the QR code for attendance will remain visible on the screen for 5 minutes to allow participants to scan it and complete the form. Thank you.